So this is a summary of hormone therapy in breast cancer survivors. Hormone therapy remains controversial in breast cancer survivors due to concerns about recurrence and mortality. Non-hormonal options are the first-line treatment for menopause symptoms. This was a new clinical practice released by the Menopause Society. Hormone therapy may be considered if quality of life is severely impaired and non-hormonal options have failed. This is an explicit risk-benefit discussion. Key factors to consider: cancer type, stage receptor status, response to treatment, and time since diagnosis. Individual risk of recurrence or new primary cancer. ER-negative patients may face lower risks with hormone therapy, but data is lacking, especially in the first 5 years post-diagnosis. Triple-negative and HER2-positive types have higher recurrence risk within the first 5 years. ER-positive tumors can recur even 10 to 15 years later. Evidence limitations. Most studies are retrospective, observational, or outdated. The HABIS trial showed increased recurrence, but flawed by crossover and poor adherence. The Stockholm study showed no significant difference in recurrence. The LIBERATE trial with tibolone showed increased risk, but tibolone is not available in the United States and differs from standard hormone therapy. No evidence of increased breast cancer specific mortality across the studies. 15.2% of survivors in one real-world study reported using hormone therapy. So clinical recommendations: they do not routinely offer hormone therapy to breast cancer survivors unless menopause symptoms are severe, non-hormonal options such as SSRIs, gabapentin, vaginal moisturizers fail. A shared decision-making conversation must take place. When to consider hormone therapy and select patients: carefully screen low-risk survivors. Symptoms are debilitating and patient understands the uncertainties and risks. But before initiating hormone therapy, they suggest review tumor pathology, recurrence, risk, and treatment history. Evaluate time since diagnosis and menopausal symptom severity. Discuss the lack of long-term data and the need for regular monitoring. So takeaway clinical pearls. Avoiding hormone therapy across the board may not be patient-centered. Some recurrences may represent new primaries, but not true relapses. Real-world practice reflects increasing nuanced use of hormone therapy in survivors. Always approach hormone therapy in breast cancer survivors as a case-by-case decision. Include the patient's voice and values. Informed consent is absolutely essential. Track symptom impact on a daily function, relationships, sleep, and work. Make sure you document decisions and discussions thoroughly. Make sure you continue to advocate for and support research using contemporary hormone therapy regimens to close the data gap. This is definitely a start and really exciting place to at least start the conversations for breast cancer survivors.